about where we are in the process. So in terms of the guideline work, the top row of the project, we are in the synthesized deciding space where we're gathering evidence. And it's been fascinating because we've been gathering qualitative evidence, rich health economics evidence, as well as the effectiveness evidence. And these have been really interesting on diverse topics. And we will next year be planning more for the dissemination. But the reason we're here today is around the cross-cutting learning. Now, the learning has really, for me, been in the doing and getting more into the depth of how we do this adaptation. But today's learning is really to say that we're, as adult learners, how do we, work together on building our own capacities as we go? So I think this is where I hand over to Anka. I haven't introduced myself. I don't know I don't know everyone, so welcome to those that are here. My name's Tamara. Kredo, I'm based at the South African Medical Research Council, and I'm involved with clinical practice guidelines. I'm in the Health Systems Research Unit. We're involved with guidelines, evidence synthesis, and really trying to work out best methods of supporting and building partnerships really with ministries and researchers so that we can all, do the roles that we are trained for respectively and support each other. So, okay, Anka, I've said enough about me. You can introduce yourself. Thanks.
Oh, thanks, Tamara. Good afternoon, everyone. It's really lovely to see everyone at this kick-off meeting of the Gela Community of Practice. So my name is Anka Rova. I'm at the Center for Evidence-Based Healthcare at Stellenbosch University in South Africa. And part of my role is also in terms of generating evidence, so evidence synthesis, but also I've done a lot of work in capacity development and teaching. And in my role in Gela is to I lead the work package capacity development. So some of you might have come across my name at some point, maybe when you did the primer or other courses and activities that we have offered so far. So, sorry, Tamara, can you just, didn't know that they were animations. Yeah, that's fine. So I thought, for all of us to just be on the same page in terms of what is a community of practice, just to give a short overview. So, and I put a definition that is quite useful, I think. So communities of practices are groups of people who share a concern or a passion for something they do and learn how to do it better as they interact regularly. And I think that's why we're all here today. We all share a passion for evidence-informed decision-making, guideline development, and evidence synthesis. And I think it's a really exciting opportunity to learn from each other. So some sort of activities that characterize a community of practice, I've listed them here. So it's social interaction, so interacting with people in formal or informal settings, in person or through the use of communication technologies as we are doing now, but also to share knowledge that is relevant to, the common passion or the common, concern or interest that we have. Knowledge creation, so developing new ways to perform things or to complete a task or to solve a problem. And also to build identity, to acquire professional identity or an identity of being an expert in the field. So I thought these were quite helpful just to think about, what is a community of practice. Sorry, and I've listed some other activities there that might help us think through, what is it that we want to do within this community of practice. So it's about, being able to solve problems together, to request information from each other, to seek experience and share experiences that we've had, to grow confidence, to discuss new developments, to maybe create resources that are useful for future, to enhance collaboration. I think that is really important. And then also, okay, I think I've had that before, the discussing new developments. So, so really thinking together, sharing together, and growing together. I think that's what it's all about. And I think, yeah, like I said, it's great to see all of you here. And there's various members within a community of practice. I think if you look at that graphic that I added to the slide, we've got conveners that maybe at the beginning take on a more sort of leading role in terms of looking at what are relevant topics that we can discuss. There's core members that might be quite involved also in discussions or bringing forward suggestions for topics and maybe in future sort of leading sessions like this. And there's also members that would just like to participate and be part of the group in the background. And this is sort of, I think quite a fluid state. So I think most important is that I think everybody is a member of this community of practice, and you're welcome to really be part of the discussions, share your experiences, and put forward suggestions. Okay, next slide, please, Tamara. So really, in terms of GELA, and I think I've mentioned this. So really, the aim of this GELA community of practice is to share knowledge, experience, and relevant information through supporting the interaction of guideline development group members, steering group committee members, as well as GELA researchers. And this is across South Africa, Malawi, and Nigeria. And I didn't put our other project partners who are in Norway, for example. They're also part of the GELA team. But it's a nice opportunity to learn from others in a different context as well. So I think that is what is quite nice about this community of practice. So we've got a WhatsApp group that we set up for informal engagement. It hasn't been very active, I know, but there's still opportunity and room for improvement there. So we did share the link to the WhatsApp group, but I'm happy to also post it in the chat again if anybody wants to still join that group. And then we have what we just termed the more formal engagements, which is meetings like this on Teams, which we propose to have every 3 to 4 months. And we'll be discussing some topics or potential topics for next meetings. And we thought that we might just keep this slot as a regular slot instead of circulating a doodle poll every time to find a slot. I think maybe, and I hope this works for most people, but let me know if there's another time, if this is really not working well for a lot of people. Okay, so if you can just click one more time, Tamara, and then because what I would just, before we get started, I would just like to get I know we put forward our names in the chat, and great, thank you for doing that. But I just wanted to know, maybe get an overview of where people are joining from, what your role is within GELA. So if you can go to menti.com, so you can use your phone, it works quite well on your phone, or you can use the link that I'm pasting in the chat, and you can also join from your laptop or your computer, and just let us know. And I'm not sharing my screen, so maybe I should do that tomorrow. So I'm going to share, and then you can see, you should be able to see my screen, right?
Yeah, we can see it well.
Okay, so just for us to get an idea of where are people joining from, and we'll use this a bit later in the discussion as well, just to talk about next steps and suggested topics. So it's a nice way of warming up to Menti. So we'll just give a few minutes for people to join. Hey, a lot of us from South Africa joining. Nigeria. Is there no one from Malawi? It doesn't look like there's anyone from Malawi joining, actually. Okay. So great to see that we have some people from Nigeria, from Norway. Hi, Elodie. And yeah, a lot of us from South Africa. Hopefully at follow-up meetings, we will also have a few participants from Malawi, I think that would be great. Okay. Just giving the last few seconds to answer, but I think we've got a good idea, and it's, yeah, thanks for. Okay. And then just to get a sense of also who's in the room. So what is your role in GELA? Are you a guideline development group member? Are you a steering group committee member? Or are you a GELA team member, like a researcher as part of the GELA team? Okay, a lot of guideline development group members. Great to see that. Steering group committee members as well as GELA team members. And it's nice to have a mix of all of these different roles. So yeah, so welcome again, everyone. So we'll come back to Menti at the end of the presentation. So you can just leave the tab open or leave it open on your phone, because we'll just continue with some of these questions in order to look at suggestions for next topics, for topics and next steps. Right. I think, Tamara, I'm going to hand back to you. I think we've got a good idea of who's in the room. So thanks, everyone.
I have a feeling some people maybe didn't manage to connect to Menti yet. So because the numbers weren't tallying with the numbers in the room, but nonetheless, it gives us a good indication, and welcome everyone. So just to recap, welcome everyone who's just joined. You're welcome to add your name onto the chat so that people can be introduced. I thought I would, in just a short amount of time, recap a little bit on what the kind of accepted global definitions now are of clinical practice guidelines. Where do they fit into the ecosystem? Talk a little bit with you about the rationale and who's affected by them. Share the kind of quality criteria for guidelines, and then I was going to take us through the process of guideline development a little bit, but let's see how the time is doing and if there isn't any other discussion. Before I start, just to say that I've had an experience previously of being part of a community of practice, and I was very skeptical, as I am. I don't know, it's built in, but I was surprised by how much learning there came from different people coming and sharing different concepts and ideas. So today is a little bit more webinar-ish, but I'm hoping we can have some discussion. But the key things were, it was orientated around adult learning, it was relevant for me, and the time felt worthwhile, you know, worth being spent in that way, because time is so precious these days. So I think we will just keep open to your guidance and suggestions about making sure that this, that this becomes a relevant learning space, and if this is aligned with what you're interested in. Can others see a blank screen, or can you actually see my slides?
It's blank, Tamara.
It's a blank screen, Tamara.
It's got like it's my connection cable just cranked up. Let's see if I can reconvince it to work. Yes, okay. I think we will. There we go. Oh, why it's on the wrong one though. Okay, it's coming back. Isn't it amazing that we can connect across all these different countries? I'm still blown away by it. But anyway, so I mentioned what I'd like to cover today, but and just to say we're all on Teams. Please go ahead if you're speaking. Raise your hand at any point. You feel free to interrupt me actually, and put your camera on if you can when you're talking. And yeah, let's see how we go. So a guideline as it's kind of currently understood, includes recommendations, so guidance, recommendations intended to assist providers, recipients of healthcare, and other stakeholders like policymakers and people who have to make funding decisions. And the recommendations help the user to make informed decisions about which intervention to undertake, which tests, which public health measures to undertake, and also to select and prioritize across a range of interventions. So providing options for people. The statements, the actionable statements, determine a course of action, and they are part of decision making. And ideally, if clinical practice allowed or healthcare provision provided, shared decision making would be included. So different groups make guidelines, and so maybe I'd be curious to hear from you all. Are there any people here from government agencies? Is there anyone here from ministry on the call? Maybe you can just give a thumbs up. I don't know if you can use the react sign. Government agencies, or maybe just even working with government agencies on policies and things like that. I know there are a number of you. Are there any people from specialty societies or professional associations? Public health associations? Just thanks, Heidi Decker. That's great. Okay. Perfect. So yeah, there's a little button at the top called React with a smiley face. Okay, that's great. Good to see where people are at. And then we probably have quite a few healthcare practitioners in the room, perhaps. Maybe give me a sign if you're a healthcare practitioner. Clinician, pharmacist, doctor, nurse. Okay. Can't be that we only have one. Can it? Maybe. All right. So we're all coming from different places, but it's interesting to think about where guidelines, where evidence-informed, why do we do evidence-informed guidelines? So historically, there have been different models of healthcare, and I'm not going back too far into the distant future, into the distant past, but there was a period where, just even the disease model, the pathogenic model kind of came up, and people were just treating based on mechanisms of disease and pathophysiological principles, and that was sufficient. And then was introduced clinical training and thorough traditional health training, including the use of kind of clinical examination and some common sense. And then the kind of evolution of kind of being understanding health and disease, and then growing experience. But increasingly there was, I see we're having just a bit of an issue there. Can you have a look at that, Anke, in the chat? Thanks. So this, traditionally this was done, but as, and therefore decisions were largely based on experience and skill, and healthcare teaching was dominating the space. But as there was an increase in the research evidence, increasingly in the 70s, 80s, and 90s, you have examples of people receiving ineffective or harmful interventions over protracted periods, excessive or too much over-treatment, wide variations in practice. And I think many of us would acknowledge that that's still the case. We have a lot of over-treatment, over-diagnosis, lots of testing, tests that are never actually looked at to make decisions, variations in practice, so lack of standardized practice. And I think one of the stark examples from the kind of 70s and 80s was the use of corticosteroids for kind of preterm babies, or preterm babies born early, where the number of clinical trials, placebo-controlled trials, continued for a period of about a decade, longer than if someone had done an analysis and looked at all the studies. They would have seen very quickly that the very cheap and easy to deliver corticosteroids would improve mortality for babies and their lung health. So that's an example where there was continued variations in practice. And so this has been part of the evolution of guidelines, was kind of incorporating evidence in the decision making. So the birth of evidence-based medicine, and thanks to Michael for some of his slides here, which includes the combination of conscientious, explicit use of best evidence along with kind of skills and expertise. So someone obviously has experience and skills. We have evidence, and then very importantly in that triad with the evidence and a person's healthcare practitioner's skills in the EBM model is the patient's preferences and values. So the person who's affected and what decision they would like around their health. And this has been the evolution of evidence-informed guidelines. And it's really interesting from 20 years ago, where Ian Chalmers, who founded the Cochrane collaboration, said it's the business of policymakers and practitioners to intervene in other people's lives. Although they usually act with the best of intentions, their policies and practices sometimes have unintended, unwanted effects, and they occasionally do more harm than good. This reality should be the main motivation for ensuring that their prescriptions and proscriptions are informed by reliable research evidence. So, I mean, this has been a long-standing issue, and I think increasingly evidence-based healthcare, evidence-informed decision-making has evolved. And, you know, from being something that people just talk about, we now have some methods and ways of being able to incorporate this in what we do. So where do guidelines fit into the ecosystem? So increasingly people have, you know, the same way with integration of care, we're trying to get away from the vertical systems, although, you know, with some success and some not success. The same is that you have to think of evidence in a whole system. So, for example, step one being, you know, producing research. So, for example, the clinical trials of corticosteroid use for preterm babies. So placebo-controlled trials, but then the next step being combining all the trials done globally to make sense of how effective is this intervention, what is our totality of knowledge around this, and then that synthesized evidence going into guidelines, health technology assessments, funder decisions, policymaker decisions. And then further to that, that being disseminated and shared with the people who need to implement that recommendation. And those people then need to implement the evidence. So, and based on what happens with implementation, you can evaluate, you can do quality improvement, and you can check whether there's further evidence needed. I mean, arguably, I think we are growing quite strong in the producing evidence, synthesizing it, even a little bit into the guideline development, but this gap around implementation is massive. And I think Anka and team were involved not in the review on corticosteroid use for preterms, but they were involved with the review in how to implement that intervention. Because even though it's well known, it should be well known, it seems not to be done in the prenatal kind of space. Anyway, really, so that's where guidelines fit in here at number 3. Oh, sorry, Natasha, tell me if other people can hear me. Maybe I faded out. So guidelines are recommendations intended to assist providers, recipients of healthcare, and other stakeholders to make the best and most informed decisions. And WHO says it's systematically developed evidence-based statements to assist providers, recipients, and other stakeholders. And provide, and this is not only about clinical things, but it's about public health actions too. And it's very interesting because WHO basically were found lacking. In around 2007, there was an evaluation done of WHO guidelines, and it was found that they were very much they were expert opinion based, that they couldn't really track back the trail to the evidence that informed decisions. And they made a big change in their guideline processes to what they are now. But they made a decision at WHO, or there's some decision where any document that makes a recommendation for care needs to be underpinned by a solid, rigorous process and method. So welcome to the colleagues joining now. I'm sorry to hear that there were some challenges accessing. We're just talking a little bit about definitions for guidelines, but you're all very welcome. I won't go too much, but the Institute of Medicine also has increasingly recognized that statements in clinical guidelines need to be based on systematic reviews of evidence, not just cherry-picking information. One thing I wanted to just touch on in just a minute is that terminology can be confusing. What's a guideline? What are other things? And so, you know, you would have seen all these different kinds of things: clinical algorithms, clinical guidelines, clinical pathways, a protocol, best practice, standards of care. So some of these do have definitions. All of them may contain recommendations. And I think the critical thing, if we follow on the thinking behind WHO's process, that if there's a recommendation for care, there should be some kind of audit trail back to how that decision came about. So these, you know, you might have a big guideline, and then you would have some protocols for specific recommendations within that guideline, and many other things. I don't know if anyone else has come across issues with nomenclature, like getting, you know, different terms for different things, and what does it mean? Yeah, good idea. It's actually, I was wondering whether that was a session in itself. So maybe this is a good place to pause. So Andy's posed a question here about living guidelines. Can I check with you here? Who has come across this concept of living guidelines? You can use the react button to give me a thumbs up, or you can give me a shocked face or surprised face if you haven't. Have you heard about living guidelines? Is that coming your way in your work? Thanks for the thumbs. So colleagues, the react button's up at the top. Has anyone heard? Thank you. Thanks, Mary. I like that one. Okay. So of course, guidelines are really about giving the right information at the right time to the right person. And maybe you can also tell me, you maybe use the chat box. Maybe that's a better place. Who in the room remembers only having textbooks to guide the work that they were doing? If you're a healthcare practitioner, if you're a clinician, do you remember when it was, we only had we had textbooks. We didn't have online apps and all these things. So textbooks, who remembers textbooks? You can say yes or no in the chat. Yeah, I think there'll be quite a few younger people here who might have only, you know, have these online apps and things like that. But many of us grew up with textbooks. How long do you think it takes for a textbook to be updated? Lab coat pockets with a big fat book in it. Exactly. Question is, if you're following a textbook, and even these days, brilliant today. Okay, yeah, I think so. So we had textbooks, and even if you had a clinical guideline, I took us back to textbooks, but guidelines themselves take a long time to update. Can also take 1 to 2 to 3 to 5 years. So are we still making the right recommendations if we're using these outdated guidelines? Maybe if you are managing something like, I was looking at recommendations recently for diarrhea. I don't think those have changed a lot. There you go, Prof. Yeah, absolutely. In the past, you know, things can, in many of our countries, like we have guidelines that are ancient, but some conditions, you know, giving a salt and sugar solution for diarrhea and whatever, and some things haven't changed very much. But in some places like COVID, I mean, it was almost impossible to, there you go, Natasha. It takes ages to update textbooks and guidelines. And so increasingly people are talking about which topics are we going to move into living guideline mode. So living guideline mode means that someone is systematically searching for new evidence repeatedly or at an agreed interval. Is it weekly? With COVID, sometimes it was weekly. You know, maybe other conditions could be monthly. With HIV, there's lots of developments happening. And some topics are so fast moving to keep up. They're exploring moving guidelines into living mode. And okay, yeah, good point. Zinc dosing changes. Okay, so you'd even have to update the diarrhea guidelines. So guidelines, we're going to talk about the rationale for guidelines, but just to say that there are different modes of guidelines, rapid advice coming out quickly. There are the standard guidelines, which can take quite a long time. And there's also this thing on the table now, living guidelines. And if that's something of interest, we could definitely go more into depth with that. Andy, was there anything else you wanted to mention on that before I ask this question?
Tamara, I think it's about the standards and the processes. WHO has put so much effort into institutionalizing the use of grade, but that's discrete. It's an event. You finish, you construct the guideline, you have your grade tables as an annex. Living guidelines pose really interesting challenges to how we ensure quality while at the same time being rapid. So that's why I raised it. It's also, I think, something which brings into question how to finance that. So WHO raises money for a GDG. It's got a discrete budget. What's the community of practice really that ensures that a living guideline keeps working forever? We've done it in family planning guidance, but that relies on an ongoing system called SEER that's hosted by the US CDC and is very difficult to fund. So I think there's some practical questions as well as process questions around living guidelines.
I think it's super interesting to see how that will work. It's also, I think, another question around living guidelines is how could we collaborate? You know, if someone has gone to the trouble of having a living guideline, could us in South Africa or someone in Malawi tap into the evidence when we're working on our guideline so that we don't have to duplicate the effort? And how do we build that model globally? But now I'm taking us out there. So rationale for guidelines, lots of reasons why we have guidelines. Can I ask you in the chat box just to add why you think guidelines might be important for your work and for people, you know, our environment or for society? What do you think their role is? Maybe you can add into the chat. I do see Helen and Mary, your hands are up, but they might have been thumbs up. And maybe you can just have a check if those are just old hands. Okay. Thanks. Thanks, Andy. Thanks, Michael. Why bother, I guess, is the question. How important is it or not? Help people think about that. I do want to check if Helen or Mary wanted to ask a question. Okay, thank you for these points coming in. Mary, did you want to ask something? Improving decision-making. Thanks, Adorebe. Critical components, standardized practice, care for our patients, evidence-based, standardized care. Thanks, Amy. Yeah, improve quality of care. That's what we're certainly aiming for. So standardizing care, providing effective ideally, if we're looking at all the different kinds of evidence, effective, cost-effective, affordable, and preferred care, I've kind of left that out. Thanks, Gertrude. Evidence-based practice, especially in low-income countries. We can't afford to provide the wrong care to people. So there's actually been some arguments made that providing evidence-informed guidelines and making sure that we're using the right evidence for our environment is even more critical in resource-poor environments where we just cannot afford to waste resources giving the wrong things. And yet, I think in our systems and in our health systems, we have so many challenges with making sure that the policies are up to date and evidence-based and implementation can be supported. And that's a great point. Can be easily accessible at the point of care. Great point. And thanks, Mabel. Equity considerations in care, those are great. If best and efficient care, exactly. I think those are all true. I think someone was, I think Prof. Ezebialu was mentioning accessible care. So reducing the information overload. Healthcare practitioners or program implementers don't have time to follow all the information on every topic. So a guideline is a package of information that's already gone through tons of work to bring it down to a basic recommendation that could then be funding. Yeah. What assumptions? Thanks, Louis. That's a great question. Do you want to speak to that? Yeah. I think it's a major gap, but do you want, yeah. Shall I read it or do you want to? Feel free to talk if you'd like to. I'll go with it. So
am I still muted?
Yes, now you're not. Now I can hear you.
You can hear me. Okay. Yeah. I mean, many health systems around the world are struggling really to deliver care, and you know, dealing with burdens of disease that seem to overwhelm them. Some health systems, you know, are very short-staffed, and yet many people are dependent on those health systems that don't actually provide highly trained professionals. So, for example, community health workers do a lot of care in third world countries or in countries in the global south. So how relevant are the guidelines that we develop in those situations where, you know, for example, floods and so on can disrupt people's contact with health systems? They're reliable on whoever's around to provide care. I mean, I don't know if this is relevant to the discussion, but it seems to me quite important. If equity is an issue, and I think it is an issue.
Good. It is an issue, and I think it's a really important point. I'd love to hear what others think. So, how do we make sense of investing time in evidence-based guidelines in the context of health systems and the systems that are, you know, often stretched to capacity? I don't know what others think about that and how guidelines might be good for that or not. Yeah, Emmanuel, go for it.
Yeah, I think it may be useful to look at a more long-term sort of gain that might come from investment in guidelines, in the sense that there's some expected cost effectiveness sort of outcome in relation to the implementation of clinical practice guidelines in, you know, poorly resourced settings. So if we take that view, then it might still be wise to invest in them. Over.
Thanks, Emmanuel. Nice you have that perspective. I think, yeah, I have a few other thoughts on this. And I think, I mean, in a way, I think we don't have a choice. I think at the policy level, we have to use an evidence-informed, rigorous process to make decisions about what healthcare is recommended. But the evidence, it shouldn't be limited to, for example, the trials of what's effective and not, because then you're just adding on one effective thing after the next. The evidence that we have to scrutinize needs to be what works and is safe, but also how much does it cost? Is it affordable? And is it feasible? And is it acceptable? And would it not increase inequity? Would it decrease inequity? So there are a number of bits of evidence that need to be considered in a systematic way that decreases our chance of adding on to the system, we would hope, or making recommendations that are more implementable. But I do think where we are at the moment is we often adding on load to health systems and people that, yeah, go ahead, Louis.
I was just going to add to that list you just given. Who's going to use the guideline? Who, you know, which human resources for health are, for example, I mean, a good example I think is oral rehydration solution, which there's very good evidence that it works, and there's very good ways of making it relevant to places where health systems just don't work by, for example, training and supervising community health workers.
Yeah.
And families, actually. So, you know, guidelines have to fit into context. In Zimbabwe, for example, a little while back, you know, the usual formula for ORS is based on the assumption that you can measure a liter of water. But Zimbabwe had lots of bottles, apparently, lying around that took 750 mils. So the guideline had to be changed to allow for 750 ml bottles. I mean, that's just some examples of how important context is in bringing evidence available, you know, relevant to everyone.
I think that's critical. And I think that's another reason why we can't just take guidelines from, we can't take guidelines from WHO, for example, which has now had this global perspective. They are thinking about Russia and China and Brazil and North America, Europe. They're making global guidelines, and then we bring them to our countries. And we now want to add, because WHO says it works, but now the question is the context. Does it work in our context? Does it work for our culture? Does it work in our setting? And how is it delivered? So I think those are exactly it. And it maybe brings us back to this whole picture is that, you know, doing these things in silos doesn't work. But I think having a contextualized, evidence-informed guideline recommendation that speaks to whether something's affordable in the context and acceptable is critical. But then these steps of number 4 and number 5, particularly how it gets implemented and how we monitor implementation, it's all part of the same system to see. And I think there are lots of gaps here. So colleagues, I'm actually, we just made a start on the conversation, but I was going to talk on tons of other things, and I'm just going to scroll through and see. Actually, all I'm going to do is put this up right now, which is to say, so this is what guidelines are supposed to be. They're supposed to be clinician, policymaker, manager, funder, the people who have to make decisions for the health system. And what's missing there is people. And for managing the right patient at the right time in the right place using the right guidance, or for that matter, if it's a public health intervention like cloth masks or transport during COVID, you know, should you get into a taxi, how many people should get in? whatever it is, it's about having the right information to treat the right people at the right place and the right time. And I haven't gone into it in too much detail, but there are lots of things that we could share and learn that may or may, depending on what people find relevant, like how do we do adaptation. Andy asked earlier about living guidelines. There's just really interesting kind of global collaborative models that are evolving around how do we do this in a way where we can access the information, but we can contextualize locally, and what skills do we need to build to do that. And again, I think what came up in the conversation, amazing. You have my take-home message that I think there's a clear rationale for having evidence-informed guidelines, given that the evidence needs to include contextual evidence, but that implementation remains very challenging in our health systems. So I think I'm going to stop there and rather let Anke explore with you what you would like to discuss further. And yeah, happy to take any questions.
Thanks, Tamara. I'm just going to share my screen.
Okay, cool. Natasha, did you want to say something or stretching?
Hi, Tamara. No, I actually was. I might have missed it. I was just wondering, I've just come back from Ethiopia, and this is such a relevant talk because we went there with ideas of what is implementable, what WHO guidelines say, and you get to the ground and it's just not doable. And yet people already stretched are trying to implement a guideline that is clearly, going to break.
Doesn't fit.
It's going to be the last straw. Yeah, it doesn't fit at all. So I was wondering, is this forum open to other healthcare workers across sort of the continent?
That's an interesting one. We haven't thought about that, but Natasha, can we take that away just for some thought? Because I mean, obviously we prefer an open forum with people who might be interested in discussing how we adapt and contextualize and other things. We just haven't thought about it. So let me take that to the team. But I love that idea, and I think the Ethiopian, especially their lay health worker models, their delivery systems, they're so interesting. Their primary healthcare system is so interesting. I'm sure there'd be lots of learning for all sides. Anyway,
yeah.
Thanks for that. And Dedeke, did you want to ask a question?
I'd like to just make a comment to say that the adaptation part is the one I think is very important, because some things are doable in some contexts, and that the local adapting and adding the local context in care, especially when it comes to guideline, makes it very interesting and good. Because even if WHO says do this and then you don't have the local context to make it happen, then it's not going to be worth it. And before we know what is happening, people will go back to their old ways of doing things, of using their own understanding and knowledge, and not really things that are based on research and evidence-based. So for me, I think the local adaptation is something I think we need to really work on as individual steering committee members and then the GELA group. Thank you.
Yeah, thank you. That's great to hear. And I wonder, I mean, I'm hearing just in this short time that we have some examples of maybe where guidelines have come to us. I certainly have examples from in South Africa where guideline, and there's so many there's politics, there's so much behind the guideline process. But that it means we're trying to add on things that are not feasible to deliver with the human resources we have. So thanks for that. I'm going to hand back to Anke, and it's just great to have you all here, and I hope we'll meet again. Over to you, Anke.
Thanks, Tamara. So I've put on the screen and I see some people have already responded. So maybe just to think about future topics for meetings like this. And it's not supposed to be a webinar or us talking the whole time. So maybe it's also about things that you would like to share. And we've put forward some topics linked to guideline development. And maybe you can take a second and think about whether some of these would be interesting to learn more about. I think you can rank them in terms of which would be most interesting. And then once we've done that, we will also give you an opportunity to suggest other topics, because maybe there's something totally different that you would like to talk about or share. And I see in the chat already adaptation, living guidelines. I've actually made notes of that already. So thanks for that, Tamara. I think it was, it's such a pity that an hour goes so quickly, because I think the conversation has been really interesting. And this is what it's all supposed to be about, learning from each other, discussing relevant things. So it's great to see. So I'm just going to give a few seconds for people to respond to the Menti. And even if you want to pop something into the chat, please feel free to do that as well if you can't connect to the Menti. So thanks for all those suggestions. So this is my son Lucas. It's late in the afternoon for him, so he was missing his mummy. So he is now joining our meeting. He's 2.5 years old. All right. I don't want to keep you too long, so we can just move to the next slide, which is basically just to say any other suggestions for topics. And I see some people have put things forward in the chat. That's great to see. And we'll take note of all of that. And maybe also, reach out to some of you to maybe also share some of your experiences in a session like this. Okay, so I think, this can still run in the background. I don't want to keep anybody too long, so I'll keep this open, and please post your suggestions or post them in the chat. But I see a lot of grading of assessing qualitative evidence, so SOQUAL, looking at equity considerations. I think that's coming through. So great. Keep the suggestions coming. You're welcome to. I'll keep this open for a while. So even if we close, you can still post your suggestions. And I think the last thing just to mention is that we propose a 3 to 4 monthly meeting. And I just wanted to get sort of a sense. 3 or 4 months is sort of deciding between 4 times a year or 3 times a year. And I know everybody is very busy, but we would like to get a sense of, how often would you like to meet? Maybe you would like to meet more often or less often. So maybe also just post that in the chat, or give us an indication of how often you would like to meet. As I said, I can go back to this slide, but maybe I've got the poll here for you guys. To just for a second maybe think about this. Also, just to say that we've got a very quick, just a very short evaluation, just to get your thoughts on how we run these sessions. And Tamara, maybe you can just copy and paste the link to the forms and paste it to the chat. It's on the presentation. Yeah, thanks so much. So maybe people can just complete the short feedback form. Okay, I see. I think it's coming through. People are preferring 3 monthly or quarterly. So thanks for that feedback. Sorry. Tamara, back to you to close the session.
Oh, okay. Thanks, everyone. Yeah, just to say thanks. Nothing more to say. It's great to be together. Happy to take any ideas on the WhatsApp group. Maybe I should, if people who are here are willing to put their cameras on for a few seconds, I can take a quick picture of us and post it on our group. But just to acknowledge and thank everyone, and thanks for sharing those great stories. It's interesting that across all the comics that came in, it was about how we consider kind of the contextual stuff. And I think that's what we want to know at a national level and even subnational level, is how do we do that? So yeah, oh, nice to see people. Thanks. Maybe Anka, we can take the picture off the screen, then I can see everyone bigger. If you can stop sharing. All right. Okay, well, not quite, but there we go. Nice to see you. Thanks, everyone. Taking a picture of you. That's funny. I've never done that before. I think I'm supposed to take a screenshot, but I just had a blank moment. Cheers, everyone. Thanks. Take care.
Thank you, Tamara.
Okay. Good to see you. Bye for now.
Bye. Bye all.
Bye.
Hi, Ima.